do we have any members of the public that are present, Erin? Can you just confirm that at the moment?
We have circulated our meeting link, so we should have some joining today.
Lovely. Okay. So welcome. And can we have apologies for absence, please?
Yes. So from Daniel Carlton Conway and Asif Faizi. Fantastic.
And in the usual way, all of our declarations of interest are managed on the website. You can read them if you're a member of the public. We do, at a minimum, update this annually, and we're just about to go through finish or start a new cycle, aren't we? Any day now. I think most people have given their updated registers of interest, and you can see the web link there. So if I go straight on to just the usual spiel, which is, of course, this is a board meeting in public. It's not a public board meeting, but and we have advertised questions, which we'll come to in a moment. Minutes of the meeting held on Thursday, the 25th of March. I'm not going to do my usual and go through page by page. I'm going to ask if anybody has got any inaccuracies in the body of the minutes that they would like amended or corrected. So I'm going to take that as a no. So I'm going to ask if everybody are happy to approve those minutes. Yeah, nods all round. Fantastic. Okay, the action log. So if we go to that, there is actually just the one that has been marked as completed, and you'll see in your board papers a very full explanation about why that is considered to be appropriate to close, in that there are major differences, as of course we painfully know, between a flu pandemic and what has been a COVID pandemic, and it's felt that we need to sort of in summary, I think Amanda is saying we just need to ensure that we have, if you like, both in place rather than the one. So I don't know if David, you wanted to pick up anything on that before I move on.
Nothing additional from me, Nicholas.
Lovely. Okay. So if I then go to just calling up my agenda items, sorry. We now go to questions received prior to the meeting from members of the public. So Iram, can you just let us know what that, I think, was there one question, or are there more?
We do, yes. So we've received the question. I can read it out. Yes. The question was, given the anticipated increase of severe respiratory disease in children this coming winter, given the low levels last winter and the impact of social distancing, can the board please outline what assurance they have that there will be sufficient paediatric HDU capacity in the Harts Valleys area? So I'm just going to invite Rami for the response. Thank you.
Thank you.
Thank you. I'm Dr. Rami Aliad. I'm the Children, Young People and Maternity Lead, so I will answer this. First, thank you for raising an area that is high priority for the whole system and which we are responding to. West Hertfordshire Hospital Trust are currently reviewing local HDU and critical illness surge plans and are working with the wider health system to ensure that there are enough surge beds available in line with the NHS England letter on respiratory syncytial virus seasonal planning that was actually issued just on the 18th of May, so very recently. West Herts Hospital Trust have already participated in a stock take exercise in line with this guidance, which is feeding into regional and national surge plans. In addition, prior to COVID-19, treating children under 16 in adult ITU and anesthetic areas was being considered, and this is now being reviewed again to see if it is a feasible option if needed. But looking beyond the acute trust to support acute services, work is being done across the system to ensure that acute attendances and admissions are only for those who clinically need it. There is support from general practice in and out of hours, as well as hot hubs are available to provide first contact GP and nurse assessments for children with respiratory illness. And we have noticed in recent weeks an increase in this area. So we have actually used our ability to flex this service and increase the capacity by 50% starting as of next week. In addition to that, we have commissioned an integrated asthma and wheeze service that is in the process of being mobilized to deal with acute presentations and try and maintain them within the community. West Herts Hospital Trust has also set up a pediatric hotline which guides, advises and supports GPs to manage children and young people with the aim of avoiding hospital admission and providing alternatives to A&E attendances. So in conclusion, in line with both regional and local ask, the system is mobilizing to be prepared. And this is really a very good and pertinent question. And I thank the questioner for it. Thank you.
Thank you. I think, huge amount of time and effort gone into this. Really, Rami, you're working very closely as the lead clinician here with managerial colleagues and local government for that matter. This is really, joined up, and I really hope that the efforts bear fruit during what could be a very challenging summer, autumn and winter in this respect. Okay, and I think, Erin, there were no other questions, is that right? Okay, so I'm going to go straight on to David and the Managing Director's report, which is for discussion, please.
Thank you, Nicholas. I'm aware I have 10 minutes today, so I'll try and keep to the pertinent points. But as you can see, we have a report that is collectively pulled together by members of the CCG around lots of operational and commissioning plans that have taken place. In terms of leadership, we've already had an update in the CCG's boards in common around the integrated care system that Jane Halpin provided. And I won't go into too much detail now because we have 10 minutes on a board item after this in regards to our healthcare partnership, which will provide you with lots of updates in terms of progress made, plans for the future and developments going forward. What we do know, though, is that we're in an emerging landscape at the moment, and we need to plan as we see the legislation coming out, and we will see and understand what gateways we need to move in terms of transitioning from the CCG into what will become the ICS come 1st of April 2022. But some operational areas that are specific to Place and West Hertfordshire I wanted to raise with people today. As a result of the COVID pandemic, we know that there's been lots of issues around long waiting times for treatments. Like other acute trusts, this is something that is national, and West Herts have been working locally to improve and increase some of that capacity within the sector, and have been working closely with the independent sector to ensure that as many patients are being treated in line with their clinical needs. Really important piece of work that we're going to be monitoring and managing progress going forward, and the nursing and quality team are also working closely with West Herts Hospital Trust to ensure that all of the plans that are put in place are safe for patients, and that we make sure that we commission some of the highest quality care we possibly can in a restricted environment. In relation to some other areas around COVID, if you remember, we stood up our hot hubs at the start of the pandemic in response to being able to manage the pressures around primary care, and delivered a quick clinical pathway which has been successful across the whole patch. The hot hubs now have begun to develop in new ways, and following sort of clinical pathways and development of new pathways in the system. They're currently delivering primary care COVID, home visiting service pathways and oxygen saturation pathways throughout those 3 at the moment hot hubs. We took them to commissioning exec throughout the pandemic and iterated the version of the clinical model throughout. And a commissioning executive in May approved a further extension to the 31st of December with a 1 month's notice period for decommissioning if activity falls below an agreed level. We know that these are really important services that have helped us maintain and provide care from a primary care perspective and prevent admissions into secondary care. What we have seen over the recent weeks and kind of live information is that they have been utilised by lots of paediatric needs over the last couple of weeks, and whereas we're seeing an increase in patients needing to get different care, and also young people with viruses and colds and potential respiratory conditions that could be COVID related. So they are proving their worth at this moment in time, and we'll be continuing to monitor them to make sure that they're delivering the best commission capacity as possible. From a planned care perspective, a area to highlight is the elective recovery. When I talked earlier about the connections with the independent sector and how we may step services back up, the CCG are working closely with West Herts to support this recovery. Referrals to West Herts have increased to pre-COVID levels, and West Herts are increasing elective capacity and working towards delivering 85% of pre-COVID capacity by July 2021. This is also being supported by the development of our virtual hospitals, and these were one of the success stories during the pandemic and have been rolled out wider across other parts of the system and the country. As a CCG are working with other integrated care partners to develop virtual hospital model further, building on its original success. The current pathways developed are going to be around heart function virtual hospital and COPD virtual hospitals, and this will hopefully support earlier discharge and further admission avoidance that will be delivered jointly between our health and care partnership partners. Specifically though, conversations are taking place between West Herts, CRCH and primary care colleagues. Another area I wanted to raise was around learning disability. So this is around a cervical screening project. The project started in December 2020 and was planned to run for 10 months. However, this has now been extended to 18 months following the repurposing of unused ICS transformation funding. The Aldi nursing post has developed a cervical screening decision process document which covers MCA's best interests and looking at risk and benefits alongside resource as well, about how we ensure that we get as many people protected via this programme of work as possible. So to date, the Aldi nurse has been working with 8 practices and that should be looking to expand. Another area of transformation is around diabetes. So the first diabetes transformation next steps workshop that involved diabetes partners across the local system took place on the 5th of May. The key focus here was to further integrate and improve key outcomes for patients with diabetes. A working group will now start to develop the ideas for the model further for discussion and ratification by board in the future. From there, it will start to progress to be more around a place-based and CCG governance ask, which will look at how we begin to explore further how we can improve some of the outcomes and engage with some of the BAME patients and understand the patient's experience of diabetes care in the community. So some important work that we need to factor in here. Progress is continuing to be made around population health management. The Herts and West Essex ICS began an 18-week national Wave 2 population health management development programme in March. This work is being led by Rachel Joyce in the ICS and her team. The programme aims to enhance local skills and capacity to embed population health approaches to planned care delivery. This will include tackling inequalities, and we have discussed this in the board over the year significantly, and will also factor into a key recovery feature going forward. Action learning sets are progressing at system, place and PCN levels, so everybody's collectively learning at the same time, so we're able to implement that, focusing on data and analytics, finance and contracting. So there's some really good work there, I think, that is going to embody the way in which we develop our plans at ICS level and at place level, and will give primary care the opportunity to react and support some of those pressures that they'll be receiving. Another area to highlight is the community navigator work. We're in discussions with West Herts about the pilot scheme with Herts Community Navigation Service and Watford and Three Rivers to make phone calls to a selected cohort of elderly and vulnerable patients currently on the West Herts waiting list, just to explore whether there are opportunities to provide additional social prescribing support whilst people are waiting for their appointment. We know that people are going to be waiting longer than they ever have done, and the approach is to put in some interventions to ensure that they are managed and supported well while they're on that waiting list and their health doesn't deteriorate, or their social isolation because they're not able to engage in community and local areas in terms of relationships, care responsibilities, etc. So that will hopefully be piloted, and we'll come back and talk in more detail in a future meeting. Mount Vernon Cancer Centre is another key area. You've heard a lot about the hospital plans. You'll hear more later today. Plans to make much needed changes to Mount Vernon Cancer Centre services are now being developed to almost come into a final business plan. Funding for the developments outlined in this briefing has not yet been identified, but the public consultation on any proposals will take place before we come to a final decision. The CCG will be involved in that, and all steps will be taken to ensure that the ICS, the CCG, have input into those plans going forward. One positive to note is that work has begun to explore the feasibility of moving the Mount Vernon Cancer Centre to the Watford General site, and this is being considered alongside the outlined business case for the capital rebuild. So a couple of other areas that I want to pick up on that are just important while we've got time and then open to questions are around paediatric transformation program. Significant progress continues to be made in this area. The funding for the community part of an integrated asthma and wheeze service was agreed at the commissioning executive on the 8th of April, and work to mobilise the service has begun with a planned start date of September 21. Also, an audit is currently being undertaken with West Herts to understand the reasons for A&E attendance for children and young people and whether a proportion of these attendances could be avoided. And this will be used to form future transformation work, and something that I'll be looking to develop as part of the Urgent Emergency Care ICS board as well. Maternity services, this may get highlighted later, but the Ockenden review has highlighted a number of key actions to support safety that all trusts are required to evidence compliance with or implementation towards. The maternity team at West Herts are continuing to focus on delivering the essential action plans alongside the local maternity and neonatal system to ensure full compliance. Extra funding has been allocated this programme of work to the sum of 95 million, and that will be spread across the country so we can support to develop some of those plans going forward. Mental health as well. What we've seen over the last period of time is a growth in potential build-up of mental health needs. We know that's from primary care, and we've had lots of conversations in a clinical space about the pressures that primary care are holding. The niche of consultancy have been brought in and commissioned to provide a recovery plan for Hertfordshire and West Essex integrated care system, and are looking at the modelling and how to re-establish some of our services or transform them with the learning that we've had over the past year to ensure that we're able to meet some of these waves of individuals that are going to likely need support going forward. The plan will ensure that it engages in a wide group of stakeholders as well, including learning disabilities, services providers, commissioners, partner organisations, carers and service user groups. There is a very clear message from this engagement that this recovery plan not be seen solely or even primarily the responsibility of the formal statutory mental health and learning disability services, but an integrated one that will work alongside community navigation, physical healthcare services to ensure that there's a complete join up in those pathways. The vaccination programme is still continuing to develop, and some highlights are from our perspective. I think for learning disability programme of work commenced on February 2021. Almost 85% of LD population received their first vaccine at the writing of this paper, and we may have seen that increase over the last week or two. Children and young people also are seeing a sharp rise in needs at the moment around their mental health requirements, and we know that we have some work that we are focusing on around eating disorder services and some of the pressures that are building up in our community. So that covers some of our areas around mental health, and we have developed local primary care offer, which was talked about earlier by Avni at the boards in common, and aware of time, so I don't really want to cover too much else. I think one area before I do close that does need to be covered is the St Albans Minor Injuries Unit. It continues to remain closed, though we're now moving ahead with plans to develop the most appropriate use for the site for urgent care services going forward. We have engaged some support to enable us to go through a programme of engagement with the public and stakeholders that will be commencing in the future and will be closed off towards autumn time. And we are looking to develop what that programme of offer will be within St Albans City Hospital. At the moment, we've had some really good feedback and engagement from areas such as the St Albans Patient Group and other partners, and we'll continue to update the board on the progress of that business case. So before I finish, I just want to say that lots of work has continued in terms of developing our staff going forward. You'll see that in the HR plan. We had the ADS assessment programme this week, and 4 members of staff within Herts Valley CCG were successful in getting onto that scheme. So I'm really pleased and proud of the staff to be able to have put themselves forward into that development programme, and we'll see those individuals develop over the next couple of years so that they're ready for director roles within the system. So Nicholas, I'll leave it at that and then open up to questions.
Thank you, David. Very comprehensive as always. I've got Alison, then Thelma and Paul. Alison first, please.
Hi, David. That was a fantastic round. It was very heartening to hear about all of those various activities. I just wanted to promote the idea of giving early exposure to that kind of thing to our patient networks, to talk about a meeting we had on Tuesday on the latest issues around diabetes and the services relating to those. We ran a network event over Zoom. We invited East and North Herts patients as well as Herts Valleys. And as a result of the session, Maria Hearn gave a very good presentation on what was happening. But as a result of the session, Alan Bellinger from Herts Valleys and one of our Herts Valleys patients, and Claire Unwin from one of our East and North Herts patients, got together to they've set up a kind of a self-help advisory, gathering information, putting out information, a kind of resource for the patients of Hertfordshire, all of Hertfordshire, on the community hub that's being developed for them to access the latest information, to exchange ideas, to exchange thoughts, and anybody can sign up. And that was kind of launched as a result of keeping patients right up to speed with these things. So I just wanted to, I was so pleased with that because it was a cross-county initiative, and Claire, East and North Herts colleagues, patients jumped right in to support Alan when he went to launch this thing. So it's just a really good example of how our patients are anxious to help with the prevention and self-care agenda. So I just wanted to give that bit of good news. And the more we can do that kind of thing, the more of that kind of result we get. There's a lot of energy out there.
I'm going to make a point. We make a suggestion that we put that into the next diabetes ICAG presentation, so that actually everybody gets to hear about it. I'll talk to you later about that. Thelma.
I've got 3 questions. I had 2 until you mentioned the ads program. Thank you very much, first of all, very comprehensive report. As a lay member, it does help me to have an overview of what's going on. And to that point, my first question relates to under leadership integrated care system. Huge task we've got to do, short period of time, lots of things to be done. Is it possible to share the master plan with us so that we can see the various tasks that's being done, who is leading, and what the risks are? It will help us lay members, certainly will help me to be able to discharge the job that I've been appointed to do, which is support, constructive challenge, and can't remember the other one now, but you know, this is something we've raised before. And then my final question is the ads program. I'd like to know the diversity of those who've been successful in terms of ethnicity and the other protected groups like disability, women, etc., please. Thank you.
Jane or David want to pick up on that first? And Hein, I think you've got also want to contribute.
So I wanted to pick up on the ICS side of things, though I can probably touch on the ads bit as well. In terms of is there a master plan? There is, Thelma, but it's very light on detail at the moment because there is no detail centrally. So I'm happy to get across to you what we've got, but I can't make up national guidance that doesn't exist. We anticipate the plan becoming much more detailed as things emerge, but I just think we have to have realistic expectations about it. What I can say is we have been successful in appointing a transition director who will join us from the 1st of July on a fixed term contract basis, so that we have got some additional capacity to oversee and control that programme as well as those of us who clearly have a huge amount of influence and involvement in it, but also have day job responsibilities as well. In terms of the ads programme, Hein probably has the spreadsheet to hand, but I think there were only 5 candidates that we did not recommend of the cohort that was in front of us to go onto the programme at this time. All were recommended for different development options. None of those candidates who were not taken on, if that makes sense, came from a BA&E background. There were both men and women in the 5 who were not taken forwards, but my recollection would be that would be broadly in proportion to the overall mix of gender that was in front of us. So I think actually the cohort that is starting on ADS 5 is probably the most ethnically diverse cohort that we've had, but like I say, Hein would have the detail on that, but certainly there was a really good mix across all of our organisations, across genders and across a range of different ethnic backgrounds.
Thank you.
Thank
Hein,
you, Jay.
sorry, Hein, do you want to just very quickly come back on that?
Just very quickly, Chair. I think that the majority of the candidates were female. For Hearts Valleys, 25% were from ethnic minority, and overall we had 18% ethnic minority in the successful group.
Okay, thank you for that answer. Thelma, was there anything else that we've left unanswered?
Yes, thank you both for answering my questions. The final question I had relates to virtual hospital, which I don't know what it is, and I'd like to know if you could just quickly tell me. The reason why I asked is it something like somebody's having a heart attack, they phone the hospital, they say, don't bring your loved one in, we'll tell you what to do, and the person drops dead, which is exactly what happened to a colleague at work. We were in a meeting like this, he drops off the chair, the wife picks him up, called the hospital, they said, don't bring him in, this is what you should be doing. She did what she was told, went out of the room to get a cup of tea, water. By the time she came back, he was dead. 50-year-old man with no underlying problems. So is that what a virtual hospital is about?
No.
And I am helping her to raise funds in other hospitals.
So I can see Corinna has her hand up and she'd answer this far better than me, so I'll leave it to her.
Come on, Corinna. Yeah,
we are working on a program of virtual hospital, and I can give you loads of details about it, Thelma. I think we should do it outside this meeting, unless you really want to hear it now. It's a lot to say.
Okay.
And I'm sorry to hear about your colleague.
Yeah, it's a shock to all of us. Thank you.
Okay. Yeah, I mean, I think, can I just echo that? I think that I think sometimes what we call a virtual hospital can be misunderstood, and it's very much about delivering the right care in the right place at the right time with the right members of medical professionals. So in summary, Paul, and then I'm going to close this item down because we are already behind on schedule. Paul.
Thanks, Nicholas. So two quick questions. One is, when are we going to stop talking about BAME as a complete entity and actually recognise that it's made up of multiple different groups, including, and in particular, do we have the data, for instance, on black people? Because as we found out before, that's typically where they're most disadvantaged in the health service. And the second question relates to the finance chunk of David's report, which I think Alan has probably overseen. And the very end of it talks about expectation of a level of efficiency second half of the year likely to be more challenging. And Alan made a very good point last time that really we should be looking for system efficiencies, because that's really the way we need it to work. And I guess my question is, so what's the process in putting in place the means of delivering system efficiencies in a way that we're ready to sort of hit the ground running when we get to the second half of the year?
Okay. In terms of BAME, I don't know. Hein, do you want to very quickly reply to that?
I don't have it on hand, so I will have to come back to you, Chair.
No. I mean,
but I think
sorry. Yeah. Sorry, after you.
Yeah, I was just going to say, my understanding is that the sort of encouragement to government is to move away from that categorisation, and because it's unhelpful, and in some ways it's actually exclusive as well, because it excludes sort of white ethnic minorities and things like that. So it actually actually it needs to move to a greater level of granularity to be able to properly address the problems.
I think it does, Paul, and I agree with you, but I think in relation to an ads cohort where we had fewer than 30 candidates, we don't meaningfully get into anything in that scenario. In terms of other data, you're completely right. We've, for example, the COVID vaccination uptake, we look at a range of distinct ethnic categories, including white Irish and traveller populations who, as you say, would not fall into an overall BAME categorisation. There is a lot of work going on around this whole area to be more specific and therefore be able to identify and track progress much more clearly.
Thank you.
I think another time, perhaps the board development session, I think we should be asking Yinkan Solar, who is on, but who's really doing her thesis in this as well, to share some of that learning, because I think it's really important. But I've definitely established that when you target different groups, you need to actually take into account the fact that they're very different and that the approach and what works or doesn't work varies. So I think that the immunisation program has really told us that. But Paul, I'm getting distracted. What was your other question, just very briefly?
What's the process for delivering system-wide efficiencies from June the 1st or halfway or September the 1st or whatever? So we're ready to hit the ground running.
Yeah, Alan, thank you.
I mean, so there'll be a mixture of things. So every organisation will try as far as they can to make their own savings independent of anybody else. But there'll also be some, like procurement savings where Herts and West Essex is now a single procurement function that covers all parties. So they will be looking to amalgamate procurement opportunities to get better value for money. Pathology is another good example, though that's probably some time off yet. As well as that, there's then in each of the areas for each of the ICPs, they are looking at system change rather than individual organisational change. And one of the key things with that is to make sure that we look at cost and not transaction values between ourselves, and also avoid cost shunting. So one organisation thinks it makes a saving by shunting cost to another. So the ICPs and the ICP boards and their various subgroups will be key on this, and we already know there are a number of business cases for service change which are going through, one of which happens to be virtual hospital, and so that it's the change in lens that's going to be the main focus that will deliver the system changes, that we look at what does it do for the system as a whole rather than one part of the system commission something because they think it's better value, but actually for the system as a whole it's worse value. Yeah, and it will take time. It will take time.
It will. I mean, I guess based on our QIP experience, I would just encourage you guys to put a little bit of process around it to make sure you can capture it and count it properly and make sure that we are doing the right things. So, but it will take time.
I am going to close it at that point. I allowed it to go on because I think it's really important to get those points, but we must make sure we protect the time for the other two major items. So straight on to David, and this is for approval, and it's the establishment of the Integrated Care Partnership in West Hertfordshire. David.
Thank you, Nicholas. And as you can see, we have a paper today that notes some recommendations, and some are key around noting the progress made so far, approving the strategic milestones that we have in place alongside the name and logo of the ICP. Now, I think it's fair to note that some of this work has already been done in the Integrated Care Partnership, which will be known as a Health and Care Partnership into the future. And it's being asked to go around all of providers as well as commissioners for a discussion and debate about the content and next steps. There's lots of work that has taken place over this period of time in relation to developing the partnership and developing structures in terms of reference. We have lots of working groups as well that are looking at areas such as finance, commissioning, quality and performance, all along a host of different areas that will enable the Health and Care Partnership to actually understand the work it's doing as a system and how it can respond and integrate with one another. But in terms of this detail, I'm going to hand over now to Katie Healy, who's come along, who's the Programme Director for this work. So Katie, over to you.
Hi there, thank you very much. So as David said, this paper sets out sort of a bit of backwards looking, what we achieved over 2021 and what the impact of COVID was on that and what our plans are for 21-22. So COVID, as you would expect, impacted progress quite rightly. The focus of the majority of people in the system was on responding to that, but that did mean that we were able to, as a system, implement some really swift service transformation. And we had a session in the summer last year to look at what should the ICP be doing in this space, and it was agreed the most valuable thing would be to assess some of those system transformations and think about how we play those into the future, taking into account the kind of points that Alan makes about how as a system we assess and evaluate that. We have then, towards the end of the 2021 period, started to re-establish the programme and start the focus back again on the programme activity for establishing the ICP. We reviewed and refreshed the clinical and professional advisory group chaired by Nicholas and Mike van der Watt from West Herts Hospital Trust. We did work on the name and branding, which is set out in section 7 of the paper, and we started our thinking around the engagement, and Alice and others have been involved in some of that, how we need to engage as we're establishing the ICP and what that needs to look like when we are established. Looking forward, the paper sets out the sort of key priorities, what we hope to achieve in 21-22. And that broadly fits into two areas: what we're going to do to establish the partnership formally, and the product of that will be a governance framework, which we're working on at the moment, and then what we want to achieve as a partnership, as a health and care partnership, and the document that's going to support that is our strategy, which we're really busy working on at the moment. And a number of people around the meeting are involved in that. So as a key partner, as David said, we're asking all of the partner organisations to note our progress, look at and agree the milestones and the name and logo to move us from being an ICP to a health and care partnership, South and West Herts Health and Care Partnership.
Okay, thank you, Katie. So Thelma.
Thank you. Just the first part of 2.1, the key responsibilities, take accountability for the development and implementation of plans to transform delivery of health and care in West Herts, which I take to mean health of care of those who live in West Herts. Yet still I notice that the membership does not include either lay, that brings a different perspective, or any members of the public. Is that based on the fact that those two groups have no value to add?
Shall I answer this, David? Or I think
yeah,
no.
I'm happy to if you do. No, go for it.
The answer is that's not a reflection of that. So that's, to be clear, that's in the terms of reference of the ICP board. And so that doesn't, so the first part, yes, it is around the population of South and West Herts, and some of that work is playing through from the ICS in terms of the scope. Absolutely recognise the value of patient and public involvement in the development. And you will see that in the diagram further down, if you skim to the bottom, there's a governance structure and there's a patient engagement group which will have a number of different patient representatives on it, and the feeling that would be 2 members of that group would sit on the ICP board. So that's set out in the membership.
Tell me you're on mute.
Yeah, 3.1 refers to membership, and it doesn't, there's nothing here, unless I'm not seeing properly. It says the ICP board. So I'm taking it to mean this board, and the membership does not include any lay member or any patient. That's the question I'm asking. Are you saying they will be involved somewhere down the line, but not at the board?
The membership includes the chair of the patient engagement group, which we would anticipate being a lay member, and another member, because we also recognise that actually it can be quite challenging to be just that one patient voice, public voice.
I think there's a danger that we're going to get ourselves tied up in knots, because that has not been the way that the discussion has been flowing in terms of both patient engagement, as you quite rightly say, Katie, but also lay involvement. So David, do you want to just sort of give your angle?
Yeah, just for clarity, this board as a CCG is separate to the board of the Health and Care Partnership. The Health and Care Partnership structure does have co-production and engagement within it. We do value the input of lay members, and there have been conversations at the development sessions with chairs about how that will get engaged into that process. So that's already taken place, and there's a second development session taking place, I think, in the next month. Katie, I've seen the dates go into my diary. You're nodding. So all of that is part of the development process. In terms of the care element, we are including social care in our Health and Care Partnership as well. So that's referring to integration with the county council and district councils as well, that will be developed. At the moment, we've kept our membership to a grouping that can start to deliver the structures that enable other inputs to come in as soon as we're clearer on some of the statutory responsibilities.
This is absolutely so important, just to get this right. But can I just be clear? At some point, when the legislation goes through, there almost certainly will be some lay net involvement in an ICS board. And I would have thought that it would be very highly likely that they would want to see that lay involvement also being somehow represented in terms of ICP or health and care partnership decision making for assurance. Jane, do you want to just briefly comment on that? I know it's not for me to decide this, but I would, I think that's the flavour of the conversations we've had.
Yeah, I mean, completely reinforce, Nicholas, what you've just said about sort of the flavour of the conversations, but it also takes us back to sort of an earlier answer, which is, as it stands at the moment, we don't have the guidance on what must be done and where our flexibility lies. Now, if it turns out that what must be done gives us already a cast of thousands, I think we will want to think very clearly and carefully about how we do not get dragged into tokenism, and how we actually set up governance for the future, which delivers what we need it to deliver. So I'm just not in a position to kind of make statements about it at the moment, but absolutely, there's been no divergence from what we said all the way through, which is having meaningful and broad patient engagement at every level continues to be a priority.
Yeah. Thank you, Jane. Right, I'm going to take Paul. I'm going to take Alison very quickly, please, because we do need to do the next paper, and we have got to finish by about 1:44, no later. So we're up against it. Alison, please.
Okay, thanks, Paul. Sorry, jumping. But I just wanted to confirm that Katie has been assiduous in involving me in where possible in communications and engagement meetings and other development sessions, so that I can also keep a watching eye on the involvement of patients, as Jane says, in a broad and meaningful way as we develop. But it's so she's made sure that I'm involved, and I kind of consider it part of my continuing remit to make sure that patient engagement and involvement is materializing, is actually emerging. So just again to assure you, Thelma, we're on it, and we will make sure that we have had good range and depth, and we want to make sure that in the new form, the new structures, that will continue.
Thank you, Alison. Paul.
So observation first. The things that are described as strategic milestones, truthfully, look like a mix of operational stuff and tactical stuff and a few strategic things on there. But I mean, you can call them what you like, really. I don't quite understand whether the intention is that this at some stage will become a statutory body or not, or whether this is just our interpretation of where we think we want to go, that may or may not get overridden by sort of guidance going forward from the centre. That's point 2. Point 3, I don't understand how you have I'm putting aside the question of lay members and non-execs and stuff. I don't understand how you have a membership of the board that does not include any senior finance person, when one of the roles of the thing is to deliver financial balance. So I kind of think you may have a lot of gifted amateurs sitting around talking about finance if you're not careful. And I don't understand paragraph 3.6 that talks about a form of partnership board involving executive and non-executive leadership, what that means and where that's going to come from. And on paragraph 6.4, I suggest that you extend it to say conflicts of interest aren't just minuted, but actually you actually minute how you've actually dealt with the conflicts as well, because then you'll actually have a record of having managed the conflicts, not just of them having been declared politely as used to be the case.
Okay,
that's
Paul,
my lot.
We need to note all those, but I'm going to ask David to wrap it up because we do need to actually move on. David?
Yeah, just briefly on the first point, I think around statutory organisations, as Jane said, we don't have any legislation, but we've always taken the approach that this was going to be an alliance model of a health and care partnership. You could commission through a lead provider and have one provider that then subcontracts out to its partner organisations or member organisations. We felt the right way to begin this journey was to do it as an alliance model. There will be work streams that sit underneath it. So there is a director of finance of all of the directors of finance in the west of Hertfordshire that contribute into bringing those financial governance and papers through in terms of transformation to support. There's also commissioning work streams and they all interconnect in a kind of matrixed way. So just to give you assurance that the input is in there from all parts of the CCG and all parts of providers. We are in a development stage, so we aren't allocating resource at this moment in time. The CCG still is the commissioner. The ICS will be the commissioner from the 1st of April as well. Levels of delegation will be agreed once we're confident that all of the governance is in place that's accurate enough and safe enough to manage some of those conflicts of interest, the size of budgets and population health at that point in time. We are, however, looking at service development plans that we can bring to the integrated care system and colleagues to demonstrate that the ability of the health and care partnership to take on various delegations at some point.
Okay, so I just want to remind everybody, this is about establishment of the system, not the final document, not the final way. And if you go back to how CCG started, that's exactly what happened. The legislation came, things changed, and we will need to reflect all the comments that have been made in the discussions, and we can feed that back. But I am asking for approval, please. Do I have nods? Okay, thank you. Okay, finally, and we really are up against it. I'm so sorry, Jane and Claire.
Sorry, Nicholas. I don't want to sort of hold things up, but I'm not sure what we're approving. I mean, I don't really feel there's enough information to actually approve it, truthfully. So you can put me down as an abstain, I think.
Okay. Thank you, Paul. I think that's perfectly fair. Okay, right. Moving on. We now have the quality and performance report. Jane, Claire, and I know that Francis is also, I think, available. So who's going to lead on this? I think we do have to take this as read. It's a massive document, really clear. But over to Claire, you're going to lead, or is it Jane?
I can come in if you want to, and just maybe do a little bit more of an update on the position you've got on your packs as well. Okay. So if we look at West Herts, obviously looking at the local, you've all had some overarching information from the previous board, but looking at West Herts Hospital, we have seen an increased demand in their ED. It's been up across the board about 30%. Their end of year performance, though, did improve slightly to 80.7. And they continue to be under quite a lot of demand, but we've had no 12-hour breaches declared since January, which is good. They are managing that, and it was an unprecedented winter, as we're all aware. The other areas I think that the board will be interested to have the update on is about the RTT position. And in February, it was 72.8, showing a little bit of a decline, but March has been relatively unchanged at 72, but they're restoring the elective surgery at the start of March, and that's had a positive impact on the 52-week wait, which we'll be pleased to hear, and that is reduced slightly down by 26 patients. The other work that's going on locally is on the patients waiting over the 78 weeks, and they've looked at the prioritisation of these. The majority are P3 or P4, so the lower categories of people waiting, and those patients can also now be booked into any capacity unfilled with the higher priority cases. The other aspect that I think is important that we looked at, that there is an increasing number of patients, around about 20%, who wish to defer their surgery till after the COVID. So that's on patient choice, and we know that's through information, but I think that is worth saying. David mentioned briefly in his report about the independent sector quality assurance we're doing with process we're doing with West Herts, and Kate Chan's been supporting them to ensure that they have processes to monitor that. They will be looking at obviously using some independent hospitals, and we must ensure that our patients in South and West Hertfordshire have good quality care, and that's being monitored. So that's a new programme of work and very worthwhile. I think I'll probably, because of the time, we've literally got minutes left, haven't we? I'll pause there if Francis or Jane want to add anything to that. Other than that, I'll take some questions. I've just seen Thelma's. Sorry, Thelma, I shouldn't use abbreviations. It's referral to treatment times, and we're working really hard to make sure that these are improving.
Right. Okay. Thank you. Thanks.
Stuart.
Can I say, I think all the papers that have gone before are equally important, but we're not going to spend enough time on analysing patients and quality and performance to squeeze it into just a few minutes. It's not really acceptable. And I've already been in touch with David about the timeliness of this report. I mean, to put this report in a pack of papers, which the latest data is December, is not acceptable. It's out of sync in terms of the meetings with the Quality and Performance Committee. So we're going to have another look at that to get us back in line, because, you know, to read this report, it gives you no information in terms of where we're currently at, other than Claire's giving us an update. So I think we need to have a complete rethink now in terms of timescales, David, and the cycle of reporting. But we do need to make sure this board meeting has enough time to get in a little bit more information on performance and quality. It's not acceptable to squeeze it into 7 or 8 minutes.
Okay, Claire, do you want to come back to that first?
Yeah, and I'll always support talking more about quality, and thank you, Stuart, for pointing that out. I completely agree. We do have a plan, and I'll speak to you later. We discussed it yesterday about how we can get these more in sync, Stuart, because you're right, I have got the new paper, and that will be going out today to the Quality Committee. So it is just an update, but it is very difficult then to analyse and have a discussion when you haven't got the figures there.
I think it's incredibly important, though, we do remember that these are discussed in detail, in minutiae, in Quality Committee. This discussion here is not the discussion. I think we mustn't forget that. Jane.
Just trying to also just give some assurance. It's just been I don't mean it to be an excuse at all, but really difficult trying to get the timeframes in as we're moving through a transition period, that we're trying to work back from the board dates, the quality committees, the quality system groups, and I think we're trying to work with colleagues in governance to get these dates lined up so that you do have much more up-to-date information. So apologies for that.
Okay. Anybody else want to make a comment? I mean, there's massive detail there. I do note the stuff about the CHIT team, Claire, and it looks like that is getting resolved. I thought that was very carefully explained, because that's been a really key component of some of the detailed stuff we've been doing in terms of community and nursing homes, isn't it? Yeah. Okay. Anybody else? We've got literally a few moments, but anybody else that wants to come back with an important point, because we are being asked to approve that. Sorry, it's for assurance, sorry, to be precise. Any other comments before I move on? Okay, so with those caveats, and Stuart, we take those points absolutely fully on board. I'm going to move on now. Conflicts of interest. We didn't have any directly expressed conflicts of interest. I think we did actually have in a few parts of the papers there. We talked about the equality and diversity issues, and I think Heine will come up with some more details. And in terms of IRM, any further risks, I think I think the only thing I would highlight is we really do take on board the comments that both yourself, Paul, and Stuart have made in terms of timelines, amount of time for discussions. As the papers, as we become more integrated, we will have less complicated papers, and I think that will pan out. But I think the point's well made. Okay, so without further ado, unless there's any other business, or I'm going to close the meeting. Okay, thank you very much.
See you soon.